Good morning, dear students. Our last lecture today on etiology of malocclusion is to complete the local factors that affecting on the development of occlusion. Abnormal labial frenum. At birth, the labial frenum is attached to the alveolar ridge with some fibers crossing over and attaching with the lingual dental papillae. As the teeth erupt, bone is deposited and the frenal attachment migrates superiorly with respect to the alveolar ridge. Some fibers may persist between the maxillary central incisors. These fibers, which persist between these teeth, are capable of preventing the two contralateral central incisors from coming into close approximation. This space is called a midline diastema, which may occur due to various causes. First of all, deciduous dentition, ugly doubling stage, racial predisposition, negroids, microdontia, congenital absence of lateral incisors, supernumerary tooth in the midline, and abnormal frenal attachment, trauma, abnormal pressure habits, and finally impacted tooth in the midline. A specific test used to determine the role of frenum as a causative factor of median diastema, which is called the Blanche test, which can be done as follows. Step 1. The lips is pulled superiorly and anteriorly. Then any blanching in the interdental region is indicative of fibers of frenum crossing the alveolar ridge. This test can be collaborated with an intraoral periapical X-ray of the region, which shows a slight radiolucent widening with notching in the interdental alveolar ridge region. The other factor of local factor affecting on occlusal development is the premature loss of deciduous teeth. The premature loss of deciduous tooth can lead to malocclusion only if the cutaneous tooth is not close enough to the point of the eruption. When the permanent tooth doesn't erupt following the loss of deciduous tooth, the adjacent teeth get time to migrate in its space. This can lead to the mesial migration of posterior teeth, resulting in a decrease in the overall arch length. This might cause the permanent successor to erupt in a malpositioned or get impacted, or cause a shift in the midline in case of anterior teeth. In case of an anterior deciduous tooth is lost prematurely, there is a tendency for spacing to occur between the erupted anterior teeth. It might also lead to a shift in the midline towards the side where the deciduous tooth has been lost. If one of the posterior deciduous teeth is lost, especially the deciduous second molars, the first permanent molars erupt mesially. This might lead to a loss in the arch length. This is seen most commonly in the maxillary arch where there is lesser space for the canine to erupt. Therefore, it may erupt labially. Mesially tilting of the erupted mandibular first molars may cause the second premolars to remain impacted. Another factor, which is the prolonged retention of a deciduous teeth. Any deciduous tooth may be retained beyond the usual eruption age of their permanent successor. This may cause either buccal, labial, or palatal lingual deflection in its path of eruption, and also impaction of the permanent tooth. Most commonly impacted tooth is the maxillary canine, third molars not taken into account. The reasons for this include: it is the last anterior tooth to erupt, space occupied by the deciduous canine is less than the mesiodistal width of the permanent canines, the premolars might migrate mesially, leaving limited space for the canines to erupt, and it has the longest path of eruption, and on controversy, as it may see, it is the only tooth to erupt after root completion. Delayed eruption of permanent teeth. The sequence of eruption has a certain amount of flexibility, but if one of these teeth doesn't occupy its designated place in this sequence, there is a likelihood of migration of other teeth into the available space. The cause of the delayed of eruption is either due to early loss of a primary tooth leading to mucosal thickening, or due to presence of odontomas or tumors that lead to block the eruption and inhibit the eruption of the permanent tooth, or presence of a supernumerary tooth, mostly the mesodens, in between the central incisors. Ankylosis. Ankylosis is a condition which involves the union of root or part of a root directly to the bone without the intervening periodontal membrane. As we see here, this tooth is usually in a low level of the occlusal plane, and the ankylosed tooth lead to severe problem and also displacement of the adjacent teeth. Also, it should be suspected in cases where there is a past history of trauma or a mobile tooth has regained stability. Dental caries. Proximal dental caries is especially to blame for the reduction in the arch length. This might be brought about by the migration of adjacent teeth or tilting of adjacent teeth into the space available and or supra-eruption of the teeth in the opposing arch. This is especially true for deciduous molars, which can be by themselves cause improper dental restoration. Improper dental restorations can cause malocclusion. Either by under-contoured proximal restoration can lead to a significant decrease in the arch length, especially in the deciduous molars, while over-contoured proximal restorations might plunge into the space occupied by a succedaneous tooth and a reduction in this space. Also, overhang or poor proximal contacts may predispose to periodontal breakdown around these teeth. Premature contacts on over-contoured occlusal restoration can cause a functional shift of the mandible during jaw closure. And finally, under-contoured occlusal restoration can lead to the supra-eruption of the opposing dentition. Abnormal pressure habits and functional aberrations continue to be the most evident factors that affecting on the occlusal development, including abnormal sucking like thumb sucking and finger sucking. As we know, by this positioning of the thumb, the tongue will be in a low position and the teeth will be in apart. So the pressure applied during this habit lead to an anterior open bite. Also, tongue thrusting, we discussed it previously on tongue as a soft tissue factor, on the general factor for malocclusion, also contribute to an anterior open bite. Lip and nail biting also produce retroclination of the lower incisors if the lower lip biting behind to the upper incisors. Abnormal swallowing habits like endogenous tongue thrusting, swallowing with the endogenous tongue thrust can lead to an anterior open bite and narrowing of the upper maxillary arch. Respiratory abnormalities. Nasal breathing is the correct way for the physiological respiratory breathing, but if there is mouth breathing rather than nasal breathing, there is disturbance in the pressure from the outside and the inside, and this leads to the collapse of the maxilla, and narrowing of this arch lead to crowding, and also as well as may be associated with increase in the vertical dimension of the maxillary arch. So this could lead to several malocclusions and complicate the case of the patient. And also psychogenic habits and paroxysm lead to decrease in the length of the teeth, as well as there is gum recession, attrition. All these can lead to a kind of malocclusion. All of these habits are functional aberrations which produce forces that are abnormal. Since these forces are produced repeatedly over time, they are capable of bringing about a permanent deformity in the developing musculoskeletal unit. These forces its effect and severity depends on three main factors of the habits, including the intensity of the habit and frequency and mainly the duration of the habit, all these together affecting on the severity of the habit on the malocclusion. This forces affecting on the function by Moss theory, functional theory, which is in simplest way that it is function creates form and normal function creates normal form. And thank you for your listening.